Good morning, good afternoon, and good evening, everyone, wherever in the world you may be joining us from today. My name is Francesco Del Carpio, and I am the CFA York Operations Coordinator. I would like to officially open the 7th 2024 session of the Emergency Management in Hospitals and Healthcare Speaker Series, which is being presented in partnership with the Thunder Bay Regional Health Sciences Center. I will begin today's session with a land acknowledgement. We acknowledge and recognize that many Indigenous nations have long-standing relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Tikaronto and has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation. The territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event and our participants may be joining from various locations, I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speakers, and our participants from around the world. Welcome to our webinar. It is now my great pleasure to introduce our moderator, Misha Richard. Misha Richard is the current Emergency Preparedness Lead for the Thunder Bay Regional Health Sciences Center in Thunder Bay, Ontario, Canada. In this role, she acts as a subject matter expert, assisting with the development and maintenance of emergency management governance, training materials, and exercises. Misha also volunteers as an editor for the Canadian Journal of Emergency Management and is happy to be a collaborator and facilitator for the CFA York series. She holds a Master of Disaster and Emergency Management degree from York University and bachelor's degrees from Western University and Brandon University in the focus areas of political science and disaster studies. Misha, thank you very much for moderating today's session and your ongoing support organizing this series. The floor is yours.
Good morning, everybody. Thank you for tuning in and welcome back after our break. I'm excited that last year we had 6 sessions and this year we end up with 8, and hopefully we can keep this momentum going. I'm very excited to introduce our first speakers that are with us from New Brunswick, Canada. So I'll start off in no particular order by introducing Matthew. So Matthew Woodall is an accomplished emergency manager with a specialization in healthcare and access and functional needs. He is currently the lead emergency management advisor for the St. John area of New Brunswick's Horizon Health Network, which covers all the facilities along the Bay of Fundy, including St. John Regional Hospital. He's also the organizational lead for Radiological and Nuclear Preparedness and the lead author on Horizon's All Hazards Plan. Previously, he worked as an emergency manager with the Saskatchewan Ministry of Health, and he's also a private consultant and author. We also have Dr. Christopher Doiron with us. Chris is an emergency physician and the disaster management lead at St. John Regional Hospital's emergency department. He's also an embedded physician with the Canadian Armed Forces, where he has experience in nuclear emergency response and decontamination. So thank you very much for being with us today and presenting on this topic. I'll do just a little bit of housekeeping before I turn the floor over to you, which is to remind all of our participants, in case you are new to the series, the chat will be open to you, so you can certainly discuss amongst yourselves, and share information in there. But if you have questions that you would like our speakers to answer, please put them into the Q&A, and I'll be monitoring that throughout the presentation. We'll try to get our questions to Matt and Chris as we go along. So without further ado, I will turn it over to our speakers today. Thank you so much.
Perfect. Thank you very much, Misha, and it's a pleasure to be here. Chris and I are coming to you today from the city of St. John, which is located on the traditional territory of the Wolastoqiyik, sometimes called the Maliseet. And New Brunswick also encompasses the Mi'kmaq and the Passamaquoddy First Nations. And so we acknowledge that we are on their traditional lands and work towards building right relations with them. So it's a pleasure to be here this morning, and I'm going to share my screen and make sure that everyone can see it. So as Misha said, my name is Matt Woodall. I'm the lead emergency management advisor, and it's a very busy position, covering a number of hospitals, other inpatient facilities, and community health facilities, clinics, and places like that. And Chris, I'll give you an opportunity to introduce yourself as well.
Yeah, absolutely. So as Misha said, I am Dr. Christopher Doiron. I'm the emergency preparedness lead here at the regional. From a nuclear preparedness training perspective, though I don't have the meter course, I am a Canadian Forces physician and I'm CBRN trained. Early in my career, I was posted to Halifax, where I was had additional training in nuclear incident response and was part of the response team for several years. There we exercised a couple times a year in preparation to respond to potential incidents on visiting nuclear powered vessels. I'm an embedded regular force physician, so I work full-time in the St. John Regional Emerge, but when I'm not on training or deployments with the military. I've been part of many MCIs and CBRN type scenarios in my training and throughout my career. And it was sort of natural for me to take on the role of emergency preparedness lead when I joined the department in 2022. I've been working closely with Matt since that time, trying to update our MCI plans, our nuclear emergency response plan and everything. And he's been a very helpful participant in that. And we share a lot of similar opinions. And I thank him very much for inviting me to join this today. And I thank the York Speaker Series as well for inviting me.
So a little bit about Horizon. We are one of two health networks in New Brunswick. We cover kind of the Anglophone part. For those who aren't familiar, New Brunswick is Canada's only officially bilingual province. And so in New Brunswick, we have Horizon Health Network and we have Vitalité. Horizon has about 14,000 employees, over 1,200 physicians. We have 100 medical facilities across the province, including offices, clinics, public health, primary health, addictions and mental health facilities. We also operate 12 hospitals, including the Level 1 Trauma Center for both New Brunswick and PEI. That happens to be here, St. John Regional Hospital. We have 497 funded beds. The number of actual beds fluctuates a little bit. We're in the midst of a pretty big kind of reorganization. We've got a new addition to the building coming in the next few years, and so that number is going to go up. We're a Level 1 trauma center, and we're a 24-hour Level 1 trauma center with access to all of the things that are necessary. We are also home to the NB Heart Center. NB Trauma has offices here. We operate 4 intensive care units, 2 step-down units, and we're the regional center for 4 community hospitals, including Grand Manan Hospital, which is a really lovely small hospital located on an island that's a 90-minute ferry ride to the mainland. So it provides some unique opportunities for emergency management and the opportunity to look at things in unique and different ways.
So from an emergency department perspective, we are one of the largest departments within the province, though admittedly to some of our international participants, we may be fairly small in the grand scheme of things. We're an academic training center, and we train our own integrated family emerge residents, and we provide substantial teaching support to the nearby med school campus. We have a 47-bed facility with a catchment area of about 200,000. Spanning a large geographic area across southwest New Brunswick, upwards of an hour and a half away in any given direction by car. We see upwards of 70,000 visits annually, and as Matt alluded to, we're the only Level 1 trauma center in the province, and we're also the heart center. So that makes us the first stop for many critical patients across the province. We are quite busy. Myself and my colleagues work at 3 community hospitals, which are located up to an hour away. And our department is the main referral center for all these departments. Next slide.
So the risk and the reason that we have to have a good radiological nuclear plan is that we are located within just about half an hour of the only nuclear generating station outside of Ontario located in Canada, at Point Lepreau. It's a CANDU reactor. It was commissioned in 1983, went through a major refurbishment in 2012, and we just went through a relicensing process, and they are now licensed to operate for, I believe it's right through until 2033. And so there are some risks there. They operate a single reactor, But because of the work that has already gone into the site, it was actually, the site was designed for 2 reactors and they only ended up building 1. But because of the work that's gone into the site, it's also likely going to be home to small modular reactors and other things in the near future. They also provide kind of medium-term storage for nuclear waste that they generate, and also are a major energy producer. When they are operational, they produce up to 1/3 of the province's energy. And so help to reduce our reliance on other base load producers such as coal and heavy fuel oil and ones that are more carbon intensive. So we are mandated as the closest level 1 trauma center to have a plan to be ready for something that happens at Point Lepreau. And we are included in their plans, and we've developed a very good working relationship with them, where they're very collaborative and are very helpful in making sure that we have the information that we need.
And from a proximity perspective, they're essentially in our backyard. They're only about 50 kilometers down the highway, and they're right roughly in the middle between from the St. John Regional and Charlotte County Hospital, which is one of the hospitals that we service and could potentially see some of the patients in the event of a nuclear incident.
And then there's the real risk. And one of the steep learning curves for me was understanding the preparedness and all of the work that goes into ensuring nuclear reactors are safe. New Brunswick, in St. John, we are home to the Port of St. John, which has just doubled its cargo capacity and is on the way to tripling its cargo capacity within the next 6 months as we install 2 more intermodal cranes. We also have a very large railway yard that serves Class 1 railways. NB Southern runs it, but it does serve both CN and CP. We have significant road and rail transport throughout New Brunswick. Anything that runs between Halifax and Montreal runs through the province. In addition, with our heavy industry, we have radioactive isotopes that are used for non-destructive testing in various industries. We have Charlotte County Hospital that is quite literally a stone's throw away from the US-Canadian border, and in times of unrest and uncertainty, that's always a risk that we have to be aware of. We're also located less than 100 kilometers from CFB Gagetown, which is one of the major training sites for Canadian forces. And so our radiological and nuclear preparedness plan has to encompass all of these risks, not just the generating station. So our current state is that we rely very heavily on our partners to provide the training. Point Lepreau is an excellent partner, and NB Power are excellent partners and are always happy to come and provide us the training, but that requires them to take their staff away from their jobs to come and provide training to our folks. We also rely heavily on Health Canada and the meter training. And again, there's restrictions there in that Health Canada only has a certain amount of funding for meter. And so we aren't able to get it as often as perhaps would be helpful. Internally, we've had significant post-COVID turnover. We have had a large number of people who have resigned, retired, or moved on to other healthcare positions, other locations. And so we've lost some of our institutional knowledge, and we're having to rebuild some of that. And we have minimal human resources. I am one person. I am one person of a team of 4 for all of Horizon. And so it is difficult to maintain competency and to be able to do that knowledge transfer in an effective way.
So from an emergency department perspective, currently we only have 3 physicians who have completed the meter course. Sort of national level training. Their training was fairly remote, and certainly to finding time and funding for this course very difficult. Our nurses do complete an online nuclear incident module during orientation, but much like the physicians, they're all perishable skills, and we haven't practiced our nuclear response since the last Canadian Nuclear Safety Commission exercise in about 2019. But fortunately, our nurse educators do have some experience in previous exercises, and we are providing some refresher training for our upcoming exercise for this. But ultimately, in our current state, we'd be relying very heavily on Point Lepreau nuclear generating station to support our response. And that puts us at a substantial deficit. That lack of familiarity would really set the stage for a lot of fear and uncertainty should a real incident occur. So not unlike the general populations, the word nuclear incident would incite a lot of fear within our department. And despite the training and the understanding of the difference between contamination and exposure would no doubt be a significant hurdle in our response. And then we're left trying to develop strategies to combat these notions, mostly training, but even still, we're at a of substantial departmental disorganization should an incident occur. Next slide.
Yeah, and one of the institutional challenges that we face is that the understanding of nuclear risk is sometimes the risk is sometimes overstated, and the understanding of the actual risk isn't always there. And so we have to be able to communicate that clearly, not only to our folks in the emergency department, but our folks throughout the hospital who may come into contact with a patient or have concerns about their exposure.
And all of this planning and preparedness is in the context of many significant challenges within our department, which I know are ubiquitous to departments across the country, and talking to colleagues across the world, ubiquitous across the world. So, overcrowding coupled with the ongoing nursing shortage have produced conditions where we're working at about 130% capacity at any given time. Nuclear incident with even just one patient has the potential to profoundly impact a department operating at optimal performance. And an incident in our department full of admissions has the potential for a real loss of life. And then there's the other challenges like maintaining currency and mask fitting, which is a constant challenge. And we're currently in the process of getting at least a portion of our department updated for an upcoming exercise in October. But perhaps one of the biggest impediments to planning for nuclear incidents is the multiple competing priorities. Our leadership is inundated with new and old projects that are designed just to keep the lights on. A nuclear incident is a high acuity, low acute occurrence event. And when you look at the big picture, practicing for a likely MCI scenario, or even just ensuring everyone is up to date on the annual training requirements, often seems like a more useful use of time and energy. That said, though, all training in MCI has commonalities, including triage, resource allocation, considerations, and staffing concerns. And I've been pushing that message within my department, and we're in that we are able to practice many of these items while training in an incident that could occur and would cause a lot of fear and anxiety if we're not prepared. It's often also given us the opportunity to look at our MCI plan as a whole, which the last major revision of which occurred in 2017. Though it's a decent foundation, it lacks many of the items common to other disaster management plans. It does not contain any job action sheets. It focuses heavily on the ED, taking on many of the roles that should be performed by the larger hospital emergency management structure, including alerting various departments, alerting the blood bank, organizing beds for boarded patients in the department. And Matt and I have had many discussions regarding this, and we're both of the agreement that updating our plan to offload many of those functions to his team and the hospital writ large, so that we can focus on medicine and providing the best care possible for our patients. And given the age of our plan and the fact that COVID severely impacted our operations and derailed any sort of MCI planning and practice for some time, it's been a long time since we practiced. The turnover that we've seen over the last several years has left us with limiting nursing and physician experience and knowledge in our MCI plans, particularly the nuclear plan. So this upcoming exercise has provided us an opportunity to get past that and engage some of that residual institutional knowledge so that we can incorporate some of our junior staff in this planning process and hope that we can leverage that during this exercise to get more of our department at least aware of our MCI plans and the plans that exist. So, and then finally, like everywhere else, funding's an issue. We can't expect people to work for free, and nursing and physician taking nursing and physician resources from an already overloaded department to do tabletops and walkthroughs is not an option either. For us, we've had some success getting some money to pay our staff through the department, but there's no specific MCI budget for which this money comes. So that's a constant challenge as well. Next slide.
And one of the things that we've really tried to focus on, the emergency department is the pointy end of the stick, if you will. They're going to be the first people to receive a patient. They are going to have the least amount of notice, but we have been working really hard to make sure that the plans that we're putting together are ones that are interoperable and will work well with the rest of the hospital. And so the conversations that we're having with our other departments are not only about how are we looking after a patient within the emergency department, but how are we moving someone if they need to go for surgery or imaging. What are the things that we need to be doing to ensure that our staff and patients and visitors are aware that because something like this, there's likely to be some social media, there's likely to be some regular media, and there's going to be elevated concern. And so how do we focus on making sure that people know that it is still safe to come to the hospital, and that people get the information that they need to make good decisions about their own healthcare. And so the emergency department challenges are significant, but we're trying to make sure that our plan encompasses how this patient is cared for throughout their healthcare journey, and that includes beyond the emergency department.
So all of those concerns being said, from a departmental process, we have made some headway. So to paraphrase Desmond Tutu, we're really trying to eat this elephant one bite at a time. So we've had several tabletops to review our nuclear incident response, and that led to a larger walkthrough where we walked through as a group. We identified multiple deficiencies and items that required updating, and we've updated and changed our plan in response to that this upcoming exercise. And we're currently working with facilities to ensure that all of our kit and equipment will be ready for that, and ultimately ready should the real thing happen. Matt? Or next slide.
Okay.
Awesome. So where do we go from there? So we've done the walkthroughs, we've done the tabletops. Now we've scheduled multiple things over the coming months to be prepared for this. So we've got personnel from Point La Pro coming later next week to provide us some donning and doffing training and a refresher on that. And we're going to get particular nurse educators involved in that. We are having facilities set up our decontamination tent, and we're going to set up first for that, and we're going to provide training in that, in the use of that tent, and sort of how that works. And then we're going to do a larger walkthrough with all of the players, including our charge nurses and our nurse educators, and the people that will actually be doing this, the nurses and the physicians that will actually be doing this. And that's all in preparation for this Canadian Nuclear Safety Commission exercise that's occurring late in October. Next slide.
So similar to airports, nuclear generating stations are legally mandated to have an emergency response exercise every 3 years. And so for many of us, because of COVID, so the last provincial exercise was in 2021. However, because of COVID, the health system wasn't able to participate in that one. And so for many of us, this is either our first go around or it's been 6 years since our last participation in this level of exercise. And so we are working really hard and using this exercise as the opportunity to find our way forward and to make process improvements based on the things that we've learned through COVID and based on the research and things that have happened in the meantime. So our ideal future state is one that we're slowly working towards and one that is going to take a lot of work to get to, but is one that we think is going to be more sustainable and provide better service to our patients, to our staff, to our physicians, and to our partners in emergency management. We are in the process of getting ready to post for a 0.5 position focused on emergency management training and education. This is a position that we have a memorandum of understanding that is shared. So Point Lepreau is actually funding this position. And the focus is on being able to do that knowledge transfer around radiological nuclear concerns and ensuring that that is up to date. So if any of you are looking for something, watch for that posting to come up. But that's going to be a really important thing because they're really going to be able to focus on making sure that we are building the right training and education tools. It would be, ideally, we would like to become a radiological nuclear center of excellence. That we will be a place where people can come to and get some training and get the opportunity to learn from experts. We aren't able to maintain radiological nuclear coverage at all of our facilities 24 hours a day, 7 days a week. So our goal is that we will have at least access to expertise 24/7 across Horizon, based out of the regional hospital. Ideally, once we have enough people trained, that there will be people on site who have the ability to support the immediate response because they have the training and education. And we're taking a bit of a cue from Trauma NB and from other places and looking at a doc in a box. So if we have someone who comes in who's potentially contaminated to one of our outlying facilities, whether it be a community hospital or one of our other regional hospitals, that they would have access to someone who has basic information and can provide immediate advice and guidance through a telehealth consult, through a phone call, or that type of thing. Ultimately, what we want to move to is internal training and education, that the majority of our learning and experiential training is going to be internal. Now, that will need to be supplemented and supported by those who understand this the best. And whether it's Point Lepreau, the Canadian Nuclear Safety Commission, the International Atomic Energy Agency, Public Health Agency of Canada, Health Canada, there are experts out there that are more than willing to share the information and to participate in this and to give us the guidance and advice. And our goal is to be able to use that to build our own internal training and education that we can then share with our staff and supported by those experts. And that is our ideal future state, to be able to do that.
I have a quick question then that seems to fit in particular with the last couple of bullets that you just presented. Came into the Q&A, someone was actually asking specifically about completing any sort of certification that's for CBRN. So it's their understanding that programs tend to be restricted to military or their high-level positions to be able to have that. Is there some sort of certificate that you're striving towards or aware of, or what does that look like? Obviously recognizing that there's different regional potential certificates. Not entirely sure, but it looks like you guys are more familiar with this content. So
from my perspective, I agree with the question. I've only ever, besides the meter course, I've only ever seen training within the military context. So much of our training comes internally, or from there's a nuclear course offered by the U.S. military, and there's also a larger course offered by the British military that some of our Canadian forces have participated in and have had certification in. But besides meter, perhaps Matt can talk to know if he's tracking any other certifications.
So I'm not aware of anything else in Canada. I do know that FEMA does offer some type of training and certification. Obviously, that's not applicable in Canadian world, but it is something that we can learn from and build towards. But certainly pursuing some type of independent certification to be able to share this is something that we would definitely consider and work towards. And it's going to take some time. It's going to take us a few years to build up the institutional knowledge to be able to share this information and to be able to meet the standards that are necessary to meet those kind of standards. But it is something that if it doesn't exist, I mean, back in my mind, it'd be fun to be the first to do it. So.
Excellent, thank you. That's the only one that's in the actual Q&A at this point in time, but I felt since we were talking about training and you were discussing all those external supports to make this happen, it was relevant to bring that up again.
So I think that covers kind of where we are and where we are going, and the way to get there is we're kind of working on it right now and figuring out what are the steps that we need to do to get to this ideal future state, and to be able to provide this level of service. And it's something that's going to take us a while, and something that we are know is going to require work, and something that is essential for us to be able to provide to our patients, to our stakeholders, and to our partners. And so, Chris, did you have any other kind of closing comments before we open it up for questions?
I mean, in the short term, so this is the ideal future state, and as Matt alluded to, it's going to take some time to reach this state. But from my perspective, the emergency department is the ideal place, and the emerge physicians and nurses are the ideal individuals in our system to help push this forward. So in the near term, with all of these training opportunities that we have upcoming, we plan on taking media images and videos from all of those events, and we're hoping to produce some short-term educational resources for our and reference material for our staff that can refer to both during training and the event of a real disaster. Our nurse educators are actively involved in that process, and they'll be spearheading much of that training to start developing that institutional knowledge that will carry us into the future. I've talked to them several times, and in sort of long term, we hope to be able to have at least a self-run exercise every 12 to 18 months on nuclear incident, and we're probably looking at a couple of years before we get into that rhythm, but that's our long-term plan within our own department, and coupled with the resources we develop from those, and then when this ideal future states comes to fruition, I am confident we can develop a strong both MCI and nuclear response plan that sort of go hand in hand.
Excellent. So I believe, gentlemen, your last slide was a blank slide for questions. And since we've had this future state as the end point of the discussion, there's more questions that tie back to the education and training that have come through in the Q&A. So one question was asking about the level of PPE that so personal protective equipment, again, trying to be conscious of who's joining us today. Also, sorry, side note, anybody that was curious about some of the acronyms, I've been doing my best to populate those in the chat. So hopefully that's kind of filled in perhaps one or two gaps. So for personal protective equipment, what are you training your emergency department and facility staff to? So they were saying, you know, level C question mark. Any feedback on that?
Yeah,
Yep.
so we're training to a level C PPE standard.
So for those of you who aren't familiar with kind of those, what that means is Tyvek coveralls with a hood, face and eye protection, as well as P100 masks with the appropriate filters on. So that is our kind of standard. Now, depending on the risk and depending on the hazard, and the expert guidance, one of the pieces that we have included in the agreement with Point Lepreau, as part of their standard response protocols, is that anybody who arrives from Point Lepreau who may potentially be contaminated arrives with a radiological expert, someone who is qualified to be able to give us advice and guidance on decontamination and exposure, and those types of really detailed things that we don't necessarily always know internally. And so at the end of the day, we will follow their guidance and advice about the level of PPE that's necessary. But our baseline is Tyvek coveralls with a P100.
Okay, so that also, since you brought up again that memorandum of understanding that you have with the nuclear facility in your province, I'm curious if you have any information to share, since we've had some questions with some folks in the chat who are going to be busy in Ontario working on some exercises and so on. 2-point question is, what was the process to be able to actually get an MOU in place? And then the general question that was coming through the Q&A was sort of any support and advice to someone that's leading the emergency management side for a couple of nuclear exercises that are coming up.
So in terms of the process, we had to build a business case, and it involved, and my boss, Sharp Shoutery, is the person who has kind of managed this whole process. And it involved lots of conversations with them and kind of going back and forth between the organizations to understand the need and what exactly would be required. If people would like more information on kind of that process, I think probably best to connect offline, and we can kind of answer that in a little more detailed way. In terms of advice and guidance around exercises, is that kind of in general, or
I think they were asking in general, but I was very curious because it sounds like obviously you have a really well-established relationship with your nuclear neighbors. And that clearly this is their exercise, but you are a part of it. And that must be a very similar situation to the participant that's on the call. So perhaps in general, some of the feedback you might suggest.
So if they're looking for, things to prepare for, it's really about understanding what the risks are, and how those risks will manifest, and then understanding how that affects not just in terms of someone who's potentially contaminated coming into the hospital, but how that also affects the rest of your hospital operations, along with things like how it's going to affect transportation and travel throughout the region. For us, if there were ever a significant, the unlikely scenario of there being a significant incident at Point Lepreau, that significantly affects our ability to support two of our hospitals that are on the opposite side of where the generating station is. And so we have to kind of prepare for that, kind of outside of dealing with our immediate needs in terms of response. In terms of participating, one of the things that I was very lucky to inherit when I started in this position 3 years ago was a really good working relationship with Point Lepreau, and to just invest time in building and maintaining those relationships, and helping them to understand why it's important, because we're not traditionally part of what they would consider their response, but for them to understand the significance and the role that we can play in healthcare. And for those of you who are in emergency management positions, one of the things that I would strongly encourage is, if you don't have one, try and get yourself a CRIS. Get a physician who understands emergency management and can help stick handle a lot of that work in the emergency department. Chris has been a fantastic resource for me and allowed me to focus on some of the bigger picture pieces, because he's focusing on the emergency department.
So that's a follow-up question that I have for you is, how do you get a CRIS? Because I'd love a CRIS where I am. So how did you go about getting that actual relationship embedded with the emergency department?
So I mean, Matt took the words out of my mouth. This is all about relationships with the nuclear, our nuclear partners at Point Lepreau, as well as relationships between Matt and I. So, I mean, I would like to hope, or like to think, that most departments have a mass casualty disaster management lead or some sort of contact, and it's that individual is the individual you need to engage, and ideally they're a champion of all of this. I can't force anybody to do anything, but it's developing a relationship early on. So when I became DCI lead, Matt made himself immediately aware of me, and he filled me in on what he has to offer, because again, I was coming from this place where I have a plan in front of me, and the plan has all of the work is on us, and that's a daunting problem. And Matt immediately made himself aware and said, that this plan isn't just you. This plan is a whole hospital process, and I've been working hard at making my department aware that this is our job, is to do the medicine. Our job is to save the lives. The hospital needs to take on a lot of these roles, and Matt identified himself. We developed that relationship, and life is a lot easier if we share the wealth, and I think that was a big piece of our relationship, is Matt made me aware of what he had to offer, right? And Matt, I don't know if you can comment.
No, and I think that again, I was fortunate to inherit kind of an emergency department that had a bit of a focus and concern about emergency management and being prepared. And Chris is actually the second position that I've worked with, and there were others ahead of time. And so it really is about that relationship building and that ongoing conversation to make sure that we're understanding each other's needs, and that we're ready and available to talk to people as needed.
And I think what Matt does particularly well is he's a presence. So it's easy to sit on the other side of the hospital and never come down and see us, but Matt is regularly in the department. He's has his pulse on what's going on in the community, and if there's an issue, he comes down and gives us a heads up. It's that presence of knowing that we have a resource available to us, which is a big piece of that relationship.
So basically it all starts with reaching out. I think sometimes we make perhaps some assumptions that physicians are not on board. They don't want to be engaged. And certainly that's not true. It really depends on capacity and personal interest and just making that initial outreach. So I just want to say, like, it is inspirational to have both of you doing the presentation today, because many of the peers on the call are certainly envious of having that sort of established relationship. So it's something that's motivational to work towards. I did want to bring up, now this is perhaps a little bit of a challenging question, so I hope I'm capturing it correctly. And for anybody that's active in the chat, perhaps you might also be able to add some feedback into this. So again, recognizing that we have an international audience, somebody had put in the chat that they're involved in planning for a paramedic special operations as a part of a kind of major regional government. And they're trying to establish an inventory of radionuclear sources that exist within their jurisdiction for the purpose of pre-planning for a medical emergency first response. So they stated that they understand there's a federal database of these sorts of pollutants that's under review. Wondering about the relevance, it sounds like, sort of if anybody here has built any sort of inventory, how to go about it, any feedback around something like that. So I don't know if either of you gentlemen might have input on that, or again, anybody in the chat, feel free to add to the answer.
I would say that that's probably one of the most significant challenges in terms of planning, because we don't currently know what isotopes are outside of kind of we know what's in the hospital in terms of interventional radiology and oncology, and we know which isotopes are used at Point Lepreau, but we don't know what isotopes are being transported through the region. So yeah, it's a very interesting one, and a good question. I'd love to find out if someone has something like that.
Okay. I also had a question, which I think ties back to, we had a little bit of a pre-chat about this before we got live, which is obviously, you kind of touched on this too, I believe, during the presentation, but essentially, nuclear risks tend to be often misunderstood. We think of the boogeyman, we think of worst case scenario. And so perhaps, especially when we're talking about folks that are thinking of training scenarios and exercises, is what do you feel is the most realistic risk for your location?
So realistically, it's that unknown piece. It is the vehicle carrying isotopes for non-destructive testing that's involved in a collision. Now, thankfully, Canada has really strict transportation of dangerous good guidelines, and they're required to be transported in safe ways and well-tested and well-maintained vehicles. But it's that unknown where something could happen. I was, before I moved into emergency management, I was an ambulance dispatcher in Saskatchewan, and was part of the dispatch team that helped to manage the rollover of a vehicle carrying yellow cake uranium, unprocessed uranium ore, that required radiological nuclear expertise to deal with. Thankfully, we didn't have any patients from that, but it certainly was a challenge. And I think for people, and one of the biggest things that I can say about radiological nuclear risk is that it's really important to understand it, and to understand the difference between contamination and exposure, and to understand the different types of radiation, whether it's alpha, beta, gamma, and what those risks are. And so if you are in an area where there's radiological concern, or if you want to know more, there are some really good radiation basics courses that are available from a number of sources that will give you kind of that baseline information to really help understand your risk. I always tell people, people are always, they always pop up concerned when, oh, well, there's a nuclear generating station in the area. And I always tell them, Point Lepreau doesn't keep me up at night. I do not worry about that. It's the other things, it's the unknowns that keep me up at night.
I thought you were going to say it's cyber attacks that keep you up at night, because that's what keeps me up at night. So actually,
let's not speak it into existence.
we won't put that into the universe. I'll pluck my words back. That kind of touches to a different question that was in the chat too, which I think you kind of were touching on right now, which is, how can we get the public more involved in the planning and preparedness process for responses like nuclear response? Now, that's not something that falls specifically on the hospital to help the public be more informed and aware. But if you have feedback from your perspective, we have lots of visitors and guests and contractors and different people that are in and out of our hospitals, and also major employers, with lots and lots of people working here. How can we use our positions perhaps to help the public be a little bit better prepared around this topic? Any thoughts?
So one of the things that really helped me, and that I would encourage everyone to do, is to be aware when the Canadian Nuclear Safety Commission is having licensing hearings. That's an opportunity for anybody to go and ask questions of the nuclear facility, and to have their questions answered, and to hear directly from the facility about how they're going to manage things like emergencies, and to do that. And then when there's the opportunity to promote those open houses, I know Point Lepreau regularly does open houses in surrounding communities, to be able to share those and to be able to say, like, this is your opportunity to go and ask those questions, and to get that knowledge and to really understand more about what the risks are. In some cases, we're not going to be able to know what the risks are. We never know really what's in the trucks that are going through our regions. But where we have that opportunity, this is your chance to participate and to share the information coming from those expert sources.
And I would argue that these big exercises are also an like things are going to happen and people are going to see it, and it's an opportunity for media releases towards that, and some educational content to be put out into the media sphere to educate the public. As you alluded to, that's not really a role that we would do specifically, but I think that's a role that the Canadian Nuclear Safety Commission and Point Lepreau could take on, and then we can promote that message as required, right?
It all gets back to that relationship building and, cross-posting and supporting each other's materials. It doesn't matter if it's just nuclear, but it applies to any sort of, just what you're describing, Matthew, about what's on our roads. Obviously, there's lots of other hazardous materials that are in our communities and are on our roads. And anytime that you can share a message from one of your community partners is a really good opportunity to ensure that you have continuity in what the message is that's going out. And certainly it sounds like, you've made a couple of good suggestions here as far as hearings, and obviously, like, if exercises are taking place, to use those as focusing opportunities instead of real incidents, to get some of that public understanding. This ties into, I think, maybe one of the other questions, which was about, it's kind of a discussion point versus a direct question. I know we only have a little bit more time, but somebody was saying, is this really an opportunity to develop a course across Canada for CBRNE for healthcare staff? Could we leverage different segments like military and so on for support? And I want to comment for those on the call in case you aren't aware. So in the past, at least where I'm sitting in Ontario, the Ministry of Health did have sort of a standard set of training materials and so on, at least within the province. But all of this takes funding, it takes staffing, there's changes in government and reprioritizations. And so even within each province, it's been very hard to maintain. I think it's a fantastic idea to have something that's more standardized across the country. And Chris, Matt, I don't know if you have anything to kind of add on that topic.
Ideally, yes. This would be a fantastic thing, and it'd be fantastic, to host people from across the country and be able to kind of be that center of excellence. Like you said, it takes time and it takes investment, and it's something that we'll have to build towards. But certainly, there seems to be a lot of interest, based on that question and the other questions that have come up. And, it certainly would be interesting to start with a healthcare, to build a radiological nuclear healthcare community of practice, to be able to have some of these conversations and do this on a larger basis. And we're fortunate to have places like this and some of the other places where we can engage with people and have that. But it would be fantastic to formalize that into a formal community of practice.
Yeah, absolutely. It's just getting there, right? And as I alluded to in the presentation, it's eating that elephant one bite at a time. If we are able to achieve our ideal state, that will provide us a jumping board to perhaps spearhead some of that sort of a national level standard. But we need to get there first.
And just to build on what Chris just said, it's not only about getting there, it's about getting there in a sustainable way that we're able to sustain it, so that it's great to get there, but we need to be able to continue to provide that and to grow and to be responsive to incidents elsewhere in the world and new research and that. So whatever we build, it needs to be sustainable within our organization and everywhere. So.
Yeah, I think sometimes we get caught up on, we want bigger and better and bigger and better, but it's really a challenge to just maintain sort of a standard, to maintain a certain point of entry. And a lot of us aren't there yet. So it's like, let's try and get to that point. And on your piece, as far as, like we've got this session, this is a starting point for some of this hopefully ongoing dialogue. These sessions are recorded and they're accessible. We have a diverse group of attendees. This leads me to my last question with just a little bit of time left before I'll turn it over to our CFAL coordinator. But do you have a key takeaway that you would give to the partners, not just those that are in healthcare, but recognizing that folks that are outside of emergency management or outside of healthcare could potentially see this webinar as well? And is there a key message that you would say, if there's one thing you learned today, it's this?
For me, it's really about take advantage to build the things within your organization that are going to meet your needs, and to leverage the experience and the willingness of your partners to be able to build something that is sustainable. Use those relationships, use those opportunities to have really good conversations and to build something that is going to last.
And from my perspective, very similar to Matt, build it, but plan it. And in my experience recently is people want to engage, people want to learn, but there's a multiple competing priorities. So just plan it, just schedule it and do it, and you build a little bit at a time, and eventually that will snowball.
Well, I like to end on notes that are positive, if at all possible. So I think this is a good place to cap it off for today. We are at time. I'll turn it to Francesco in just a second, but I wanted to highlight, if anybody has additional questions, if there's things that you didn't feel we maybe answered adequately enough for you today, or you've thought of some new things, my counterpart Francesco has put his York email address into the chat, and we'd be happy to filter those questions to Chris or Matt or others as appropriate. And so, Chris, thank you so much for the presentation today. It's a really spicy topic, and I think you address things in a very even and easily understood manner. So thank you so much for taking part in this series.
No worries. Thanks, guys.
My pleasure.
Yeah, thank you so much. Just quickly, I'd also just like to echo my thanks to you both for taking the time to be here today and for that great presentation and answering all the questions that popped up from the audience. Thank you, Misha, as well, for helping to coordinate this session and the series as a whole, and for moderating today as well. And of course, thank you to everybody in the audience who takes the time to be here with us for all of these sessions. We appreciate you joining us today and always. And so just as a quick reminder, this is a monthly series, and as Misha mentioned at the start, this is session 7 of 8 for this year. So we do have one more coming up on November 6th, if you'd like to mark that on your calendar. All of those of you who are already registered will get those reminders automatically anyways, as usual. But if there's anybody in your network that hasn't joined us yet, and you want to share this with those people in your network, please go ahead. Registration will be open and is always free, and it'll be open until the very last session. So yeah, please feel free to share that. And just one final reminder as well, this session is being recorded and it will be up in a few hours on our YouTube channel, which I have put in the chat, as well as on the actual event page. It'll be embedded there. So if anybody wants to review or share the video, or just revisit the presentation, it'll be up there for your own records. And yes, please feel free to share that within your networks as well. And yeah, just one last big thank you to everybody. And I hope everybody has a great day. Thank you so much.
Cheers, everybody.
Thank you, everybody.
Take care.